Good morning, everybody. I'm John Moon with the Federal Reserve Bank of San Francisco, and it is a real privilege to be one of the sponsors for this amazing meeting, and just to be involved. Let's all have a seat. But to be involved in this a great gathering of leaders and innovators. The Federal Reserve, as you know, is the central bank and is primarily concerned about monetary policy and maximum employment. But there's also a part of the Fed that looks at ensuring that all parts of our economy are working, especially in low-income communities. And so that takes place in a lot of place-based efforts. So what I want to do is just quickly frame what we're going to talk about here, and then I will introduce our panelists, and we'll move into a discussion. So this connection to people and place is deep and profound. If you were born and you died in Navarre, which is an upper middle class neighborhood in New Orleans, your life expectancy is 80 years. But if you're born in a nearby area called Iberville near New Orleans, just 3 miles away, your life expectancy is 55 years. And so this disparity of 25 years of life raises deep, profound issues of equity and why those systems that serve one neighborhood better than another neighborhood, and really begins to draw out what we really want to discuss here today about the factors that relate to health and well-being. The Affordable Care Act, in many ways, is a response to this. It's not just about getting the uninsured, but it also addressing what health practitioners call the social determinants of health. So health and your outcomes is only affected by 10% to access to medical care. The other 50% and the balance of that is around the social determinants of health. And these things are jobs, education, stable housing, family structure, social cohesion, the built environment. These are the factors that really have an impact on health. And so the ACA is pushing us toward what's called population health. So moving us away from a health system that's currently incentivized to make money based on how sick you are through fee-for-service, and a shift toward making money by a focus on fixed payments. And so the more you can keep a population healthy, the more you can make within the health system. And so this is the shift that is happening through the Affordable Care Act and much of the work that our panelists are working on. And so this opportunity to connect the social determinants of health. How do you integrate the elements of jobs and education and placemaking to improve health to the ultimate outcome and metric of well-being, so that we can begin to reduce this disparity, this yawning gap of 25 years? I mean, it's unacceptable that if you're born in different places, that such an impact can happen as a result of just where you're born. So we have pioneers here on the panel, and I will introduce them very quickly. You can see their bios in the program. To my right, Nancy Andrews, who is the president and CEO of the Low Income Investment Fund. It's a community development financial institution. They've leveraged billions of dollars in social impact investment capital into low-income communities. We have Dr. Tony ITON, who is a senior vice president of the California Endowment, one of California's largest health conversion foundations. And Tony has an extensive background in addressing health disparities through his career in public health and now at the foundation, and is the architect of the Build Healthy Communities Initiative, a $1 billion place-based initiative with 14 sites throughout California. And Sharon Rorty, who is a senior program officer at the Robert Wood Johnson Foundation, which is the largest health foundation in the United States, and has extensive experience in urban planning, transportation, urban policy. And so really privileged to have our panelists here. So let me open it up by saying, how is your organization responding to this convergence on this opportunity to bring in the social determinants of health and ultimately start to tackle these health disparities? Nancy?
Sure, I'll lead off. So just to give you a quick thumbnail of what the Low Income Investment Fund does, it's really very simple. We take large investments of capital from private institutions, largely banks and other private investors, and then we right-size that. We break it down into small chunks of capital that we invest in community projects, primarily, as John was saying, in the built environment. So we see ourselves as a poverty alleviation organization. And about 5 years ago, because of collaboration that we have been doing with John and other partners, we began to really, in a way, it was sort of like enlightenment. We began to recognize just how important and how interconnected the issues of equality, of inequality, of poverty, and health outcomes are. And we actually dedicated our entire organization to the idea of building healthy communities, not just community building, but healthy community building. And that has caused us to transform many of the programs that we run. We're active, we make investments in affordable housing, in early learning and child development, in schools, in health clinics, in transit-oriented development, and in green investments and resilient community investing. And all of those things now we see as linking us and linking to the agenda of trying to improve better health outcomes for all Americans.
And Nancy, could you just give an example of one investment that you've made that starts to bring these connections together?
Sure. So we're in the pilot phase right now with the Kresge Foundation and with Mercy Housing to do a pilot in Los Angeles. And that pilot is taking the idea of the health revenue streams that are used by the health services, the health payment system, and we are capitalizing those revenue streams. So what that means is we'll take $100 this year and $100 next year and the following years, and we actually sum all that up, and we will make a loan in the amount of the sum of all of those dollars. So we'll take what amounts to $100 this year and turn it into $1 million that is eventually repaid to us. Now, so that's our role in this pilot. The purpose of the pilot is to use health dollars to create stable, affordable housing for vulnerable populations, in particular the homeless population. The County of Los Angeles health system believes so much in this. They know that what's going to happen is that when they finally are able to build this housing, they're going to be saving themselves money. But they needed a player like us to, in effect, forward fund those dollars so that they could get the capital part of the equation developed today. And so that's what we're doing with Mercy Housing, with Kresge, providing us a little bit of risk cushion so we don't blow up ourselves in the process of doing it. And we're in the process right now of doing the first transaction in what will ultimately be a $50 million fund for that purpose.
And that's a great, and it may sound like a social impact bond type like structure, and maybe we can revisit that if we've got time. Tony, can you talk a little bit about the California Endowment?
Sure. Good afternoon or morning, whatever it is. So the California Endowment is about 20 years old, and it is the product of, one of the products of the conversion of the Blue Cross insurance company in California about 1996. And during our first 10 years of existence, we spent about $1.5 billion trying to improve the health status of Californians and ensure access to health care for low-income Californians. And at the end of that 10 years, our board sat down and tried to figure out what difference we had made. And so we looked at the major measures of health status in California over that decade. And what we found is that those measures had not changed. In fact, they had gotten worse. And so the board decided that we needed to do something different. We needed to go deeper. We needed to understand what was driving health status in the state and try to intervene down at that level. And that's how we constructed this initiative called Building Healthy Communities, which is really, it's a commitment of $1 billion over a decade in 14 low-income California places to try to get at the root cause of poor health status and to invest in things that are shown to improve health status, with the exception of health care. That's the one thing we won't invest in because, quite frankly, it's not a great investment when you're trying to improve health status. So the nature of that work takes many forms, and we found ourselves I think very happily in partnership with people like Nancy and John and others, trying to look holistically at communities and understand what are the core opportunity structures that people need to have optimized in order to have good health. And we've divided the world up into basically three categories. One is the neighborhood and the sort of the environment that people confront in the neighborhood. Two is the educational system, which is a critical lever for opportunity. And three is what we call sort of the human service system. It includes healthcare, social services, to some extent even criminal justice. We need to optimize those systems so when the young people who are either traumatized or vulnerable encounter them, they have the best possible outcome when they're interfacing with those systems.
Great. Sharon, could you talk a little bit about the Robert Wood Johnson Foundation and how you see this convergence happening?
Sure. Thanks, John, and good morning, good afternoon to everyone. So the Robert Wood Johnson Foundation is 41 years old. If you listen to NPR, you probably hear the tagline about the foundation, but we do more than just sponsor NPR. We focused, for the last 40 years, we really focused on health and healthcare, with healthcare being more of sort of the focus on what the foundation is known for, and it is the largest health philanthropy in the US, as John mentioned. We went through a strategic planning process through 2013, 2014, and we emerged with sort of a new focus on how we're going to improve health for the lives of all Americans, and that is to really build a culture of health. And it's not that the foundation itself will build that culture of health, it's really to work across sectors, do collaborative work to get into the communities to build to build a healthier America. To work with others. So we're fairly new in the community building, the community planning kind of phase. And we don't have a prescription for how it will be done. We are really where, the social determinants of health is guiding our work, working with other foundations, working with the Federal Reserve Bank across the US, working with community development corporations and CDFIs across the country too, to really just help and understand what do people value in health? That's how we're coming at it. So let me give an example of how we're doing some of our work. We're working with the Urban Land Institute to try to develop typologies for healthy corridors. So in the last session, there was a lot of talk with the BRT system of these corridor systems to move people, mobility, right, as a sort of transect for mobility. That's important. But those same corridors that move people, buses, cars, bicycles, pedestrians, they're also transactional. These 4 to 6 lane arterials that are ubiquitous across our landscape that, usually we want to just get through them fast because they're not that pretty. They're also not that healthy. How do we but they're through somebody's neighborhood. How do we make them healthier? And again, we don't have the prescription for that, but we do know that they could be greener, they could be safer. We could manage the stormwater in different ways. So the foundation is, in a sense, partnering with ULI, look at how we can do that, to make it attractive to the developers that are going to do it, with or without us. But can we influence the development that happens in those kinds of places? And that's a big part of our work, is really influence.
And I would just add that, the other part of this is that how does it impact low-income communities? So how does BRT, how does the built environment positively or negatively impact low-income communities? And so I think that's really kind of at the core of this, about disparities and the yawning 25-year gap. Could you talk a little bit about how your organizations are working around this issue of race and equity relative to your Healthy Communities initiatives? Tony, you've got a great example, I know.
Okay. Well, first of all, I want to just say something for those of us in this room. And if you took the average life expectancy of the folks in this room, given that you're well-educated, employed, generally kind of an elite, and compared that to the 17 other peer countries that are equally developed around the world, you'd find that you all are living shorter lives than most of your peers in the developed world. And that, if you want a cite to that study, look at the Shorter Lives, Poorer Health IOM report from 2013. And it shows that even white, college-educated, employed, and wealthy populations in this country are actually living relatively shorter and shorter life expectancies compared to their peer countries around the world. So it's not just disparities that are dragging down our health, it's really our overall health is poor. But with respect to disparities, and John pointed out some really stark disparities that we've mapped really all over the country, you see differences on the order of 30 years in some cities in the United States. Those issues are deeply entrenched, and we recognize they weren't created yesterday and they won't be solved tomorrow. But one of the things that we know is that the health of populations depends a significant amount on their sense of control over their environment. And low-income people are generally mired in a fog of unremitting stress, where they're worried about virtually everything all the time. So they're forced to make short-term decisions to essentially manage all of these things they have to juggle simultaneously. And what we're trying to do is take some of the burdens off of these populations through different policies that anticipate the needs of low-income communities and actually support them being able to navigate their environments on a day-to-day basis. Now, simple thing, I mean, that sounds complicated, simple thing, a grocery store in your community where you can find healthy and affordable food. It's not something that's readily available in many of our low-income communities. A park where your children can play in a safe way and find recreational opportunities and social opportunities. These are all health protective. These are things that aren't readily available to many of our communities, low-income communities across the country. So our focus is really on this core, which is we know that there are deficiencies in these communities in terms of the built environment and the physical environment. The question is, how do you remediate those deficiencies in a way that enlists the participation of the very people that are experiencing that inequity? So our focus is really on building social, political, and economic power in a critical mass of people in these communities so that they can participate more effectively in the decision-making processes that affect the distribution of critical health protective resources in their community. There's very good literature now that shows that this notion of agency or control is critical to health. People who feel that they can manage the circumstances that they're confronted with actually are healthier. And so organizing people is good for their individual health, and collectively it's good for the health of the community. So that's our primary focus, is really building that power so people can more effectively participate in this work. So we often say that health is political, and our goal is to optimize democracy in these communities in a way that actually improves health.
And in the built environment context, there's lots of opportunities for communities to be engaged or not engaged and even have a say in the direction of things that happen to their communities that have really lasting, profound impacts on the built environment. Can you talk a little bit about how your respective organizations are dealing with that or other issues around equity and race?
Sure. I mean, our organization is really dedicated to the idea of equity. And so everything we do really is bent to try to create and improve equity. And I completely agree with Tony on the importance of social capital, of politics, political control, political access as a key de-stressor or key input that goes, or it's not really an input, it's a creation of a community that enables residents to lead better and healthier lives. There was a movement in the United States that started maybe 30 or 40 years ago around the idea of community organizing that gave birth to organizations like the Low Income Investment Fund and many other community building organizations around the country. One of them is, and this is my example, one of them is a group right here in the East Bay called Ibaltsi. They are involved deeply in the issue of health and creating better and healthier outcomes for the low-income people that live in their area of Oakland. We support them and enable them in doing that work by providing them with capital. They do quite a bit in the area of affordable housing development. We're a financier of that. We also have provided them with grant support when we can around the idea, grants for what we call community quarterbacks, which is really just a way of saying someone who's pulling all of the pieces together that need to be woven together to create a solid fabric for community and human well-being within a place. And so in many ways, what this grant support does for EBALSI is simply give them the white space. It gives them the freedom to figure out how to plan and weave collective threads, interdisciplinary threads together so that at the end of the day, they really can focus on the outcomes of producing and creating better people, healthier neighborhoods.
So the buzzword these days in social circles is this idea of collective impact and working collectively on complex issues. And health lends itself very well because it's multiple sectors coming together. Sharon or others, do you want to talk a little bit about, it's nice in concept, but it's really difficult in practice. Share a little bit about the insights that you've learned and takeaways from the various work that you've taken on.
Sure. I didn't get a chance to answer the
No,
last
no,
question.
and Sharon, and please, if you want to say something, because I know it's a deeply important issue.
Yeah,
for the
I do want to
foundation.
say something to the last question. I know we're short on time here, but I do want to say that all of the grant making at the Robert Wood Johnson Foundation happens through the lens of the population, the bottom 20% of the population, that the needs are the greatest and the resources are the least. We have recently created a health equity team. So it is all through that prism. We have in-house resources and we have we go outside the house too for resources to help us understand the needs, how to communicate the needs, and how to make sure that our grant making is targeted for the population, again, with the highest needs. So it's just very, very important part of our work. And so to this question, though, too, we are working with the San Francisco Federal Reserve Bank and Nancy's group, the Low Income Investment Fund, and other funders on a Healthy Community Challenge Grant program. It's in the design phase, and John called us pioneers. We believe that this will happen, but we'll be survivors when it does happen. Trying to create collective impact models and really quarterbacks to create funnels really to make infrastructure improvements, but really to open up the portals for these kinds of infrastructure investments that particularly help people with the greatest needs. So I know we're short on time, so I'll leave it there and let others comment on it.
And Tony, I know you've got battle scars from the work that you've done, but also very, very good progress that you've made too.
Well, I'll be very brief about this. Collaboration is hard. People don't like to collaborate. They have different agendas, different timelines. They have different cultures. So trying to get people to come together, the butcher, the baker, the candlestick maker, all together to make a meal is very hard, and we have to accept that it's hard. Typically, it's given lip service. Yeah, we'll meet with different disciplines, but then it doesn't last. So what we've done is we've funded a collaborative table in each of our 14 communities for a full decade. It's funded, it's staffed, people take notes, there's childcare, there's transportation. So people are forming real human relationships, and this is one of the things that I sometimes criticize about collective impact is that it doesn't acknowledge, A, the power differential around a table, and the fact that low-income communities need to feel like they have agency in interacting with the police chief or the head of the health department or what have you. And the other issue is that it really does take time and it requires meaningful human relationships to be forged over time together. So that just takes time and support. So we're trying to do it for a decade in 14 places throughout the state. We're seeing deep relationships being forged, and I think that that's critical to busting silos in this work.
Nancy?
Well, sure. I mean, you want me to do the second question or the third question?
Whichever.
Echoing both what Tony and Sharon have said, the work that we're trying to, we sort of woke up, I think I said the light bulb went off, we woke up a few years ago and realized that no thing that we were doing by itself was moving the dial. But we had a chance if we could figure out how to harmonize many of the things that we were doing. We didn't know for sure that we were going to win or that we would move the dial, but we knew we had a better chance if we could make these different program areas that we were investing in come together, at least through an umbrella vision. And then the idea of the quarterback, the idea of the Healthy Communities Challenge came out of that, and we're deeply engaged in that. I did want to mention one more thing that we're involved in that's trying to support this idea of integration, of quarterbacks or collective impact. We realize, just as Tony was saying, it takes dedication, it takes time, it takes a long-term commitment. We think it also takes capital. And so we've innovated a new kind of capital structure that we're calling equity with a twist that's very patient. It has a 10-year horizon. It has a very low financial expectation behind it. And it is outcomes driven in that every investee that we invest in will be measuring some of the same things. And those things are community safety and improvements around that, community health and well-being, improvements around that, child development, and child education. And we want to see movement through a very patient long-term investment. We're trying to see movement on all of those critical indicators. We have a $6 million fund that Chase has helped us put together, and we hope that we're going to be growing it more sometime in the future.
So I wish we had more time to really get into more examples of the work that we're doing, but I think it's clear that it takes more than a village. It takes a whole bringing of multiple sectors together to address the number of issues. I think one of the things I think it would be great as a takeaway here is that every one of us, individually and within our respective organizations, has an impact on health. And if we can focus our lens on improving and addressing health disparities through the work that we do, I think we will have started to begun tackling the larger issues that we're all trying to address here. So with that, please join me in thanking the panel, and thank you for your time.